Welcome to this week's Echo Diabetes in a Time of COVID-19 webinar session. I'm Dr. Nick Kutcherus, Program Director and Pediatric Endocrinologist at Stanford University. Good morning, good afternoon, good evening, depending where you're joining us from. Thank you for being a champion for people living with diabetes. We're grateful for the unrestricted educational grants that we received from Novo Nordisk and Pfizer Inc. that make this program possible. Our goal is to address the urgent needs of patients with type 1 and type 2 diabetes who require complex diabetes treatment in the time of COVID-19 and beyond. We want to empower primary care providers and clinics to safely and effectively manage underserved patients who do not have access to routine specialty diabetes care. Even before COVID-19 pandemic, outcomes for patients with diabetes were suboptimal. We must recognize that poor outcomes for people with diabetes on a population level does not reflect patient, quote, non-compliance, but rather system failure. And we as providers in a health system must change our approach to focusing on diabetes outcomes and costs. Data from 191 million people enrolled in health plans that report HEDIS results to the National Committee on Quality Assurance illustrates system failure for patients with diabetes. In 2018, less than 1/3 of patients with type 1 and type 2 diabetes had A1C values at target or less than 7%. Even more concerning, as demonstrated here on this slide, 30 to 40% of patients with type 1 and type 2 diabetes had A1C values greater than 9%. Minimizing hyperglycemia is paramount to reducing diabetes patient risks and vulnerability to infection and complications, including COVID-19. Now is an opportune time to overcome therapeutic inertia and make meaningful system changes so that patients are being able to achieve glycemic targets. We are living in unprecedented times with COVID-19, but systemic racism and health inequalities have been endemic to the U.S. COVID-19 is making these injustices more clear. We must come together as a medical community and change our practice. We must act. When the mortality rate from COVID-19 in Black Americans is at least twice, if not 5 times as high as the mortality rate from whites, we must act. When marked racial disparities in diabetes management exists, and prior to COVID-19, we must act. When Black Americans with diabetes with equivalent socioeconomic status as white Americans are less likely to be prescribed intensive insulin management regimens, newer medications, diabetes technologies proven to improve diabetes outcomes, we must act. We must act and recognize systemic racism and implicit bias that are also occurring within our medical community and practice today. Our leadership team and faculty are committed to promoting health equity through our program and combating systemic racism in the U.S. We're committed to action. Here at Stanford, we're partnering with Project Echo and other sites across the United States on this series. Project Echo is a globally recognized hub and spoke outreach model developed at the University of New Mexico to reduce disparities and improve health outcomes in patients who otherwise lack routine specialty care. Zoom-based clinics led by multidisciplinary faculty from academic medical centers and community organizations provide community providers with education, case-based learning, and expertise they need to treat patients within their own community. We have an exciting series of presentations, all of which made available on-demand sessions after their live presentation. You can access these on-demand sessions on our website, diabetescovid.stanford.edu. You can also access information on our live webinars, patient and provider diabetes and COVID resources, and soon to come an FAQ with answers to questions asked during the webinars, as well as the questions submitted during the live webinar registration process. For our on-demand session, we'll address the high-impact follow-up questions from our last session, a lecture, and we will then address pre-submitted questions from an audience member, submitting questions during the registration for our live webinar. Our case presentations are not available for the on-demand webinar. We're fortunate to have a national faculty from over 12 ECHO programs and organizations around the country. Once again, thank you all for your participation in this program. We're going to move on to the next part of our webinar, and each week we highlight high-impact follow-up questions. And a question came up last week in terms of laboratory testing and distinguishing between different diabetes types. So Jay, do you want to, I'll share my screen.
Excellent. So thanks everybody. And again, this is a really common question, particularly in primary care, about how do we distinguish between at least type 1 and type 2. And at a very high level, I think what I'd want to share with first is remember that type 1 diabetes is an autoimmune disease. So if you think of it that way, it's going to really help you sort out the tests you're going to order. So the two things that I always look at are, one, I'm going to measure insulin production because people with type 1 diabetes are insulinopenic. And two, I'm going to measure markers of autoimmunity. And while these tests are not 100%, they are really useful as your first screen. So I like to order a C-peptide, which is a measure of endogenous insulin production, which I think is more accurate than measuring insulin itself, which does both endogenous and exogenous. And you always want to couple your C-peptide with a glucose, because even in a person without diabetes, if your glucose is low, your C-peptide will be appropriately low. So you want to see a normal to high glucose with a low C-peptide as an indicator of type 1. And then the second part is that most people with type 1 diabetes do have measures of autoimmunity. Could have one or more antibodies. So GAD, glutamic acid decarboxylase antibodies, islet cell antibodies, insulin autoantibodies, or zinc transporter antibodies. And we get ours actually as a panel. So if I type in GAD, it'll actually come up with the 3 antibodies. We do have to order zinc transporter separate. If you switch over to type 2, the highlight I would say is that while there are many pathophysiologic mechanisms, insulin resistance is the one that's relevant to when we look to testing. And rarely do I do any kind of special testing for type 2. This is a clinical diagnosis that you can usually make. But if you were to order a C-peptide coupled with a glucose, it's going to be normal to high, but C-peptide will wane over time with duration of type 2 diabetes. And we don't typically expect to see autoimmune markers. And at the top there was a period of time where we were using A for antibodies and B for beta cell production. And so someone with type 1 would have measures of autoantibody, but not measures of beta cell production. So A positive, B negative. Where someone with type 2 diabetes should be, I'm sorry, that's incorrect there. Antibody should be negative and beta cell should be positive. So A negative, B positive. To the next slide. And then if you just want to highlight 4 of the most common types of diabetes, remember that type 1 and LADA, or latent immune autoimmune diabetes of the adult, are both autoimmune diseases. There should be some marker of autoimmunity. And in type 1, we already talked about the C-peptide being low to absent. In LADA, because you can often catch them earlier, it might be low normal or it might be low, but not quite absent yet. But over time, we expect people with LADA to become insulinopenic. It is important to know that with type 1 diabetes, there isn't a strong family history. 90% don't have a family history. And LADA is similar that way in that you're less likely to see the family history. If you think someone needs to be tested, TrialNet is a resource. This is a national research program looking for relatives of type 1. You jump over to the third column with type 2 diabetes. Again, we don't see measures of autoimmunity. If we look at C-peptide, it'll be normal to high. In fact, many people are hypersecretors of insulin early in type 2 diabetes, but that can get lower over time. And then finally, there's a strong family history. And then if you look at MODY or monogenic diabetes, it's completely separate from those 2 pathophysiologic mechanisms. So it's an autosomal dominant defect. There's a problem with the packaging or release of insulin. So you're not going to see measures of autoimmunity. These antibodies, if you tested them, would be negative. And the insulin, they're not insulinopenic. They're going to have normal to low insulin levels depending on the subtype. What's unique about monogenic diabetes is because it's spread by or inherited by autosomal dominant defect, this is going to have the strongest penetrance, 50% from one generation to the next. And so family history for MODY is very important. And we had a previous program about atypical diabetes. And if you want to see if your patient's at risk, because 1% of people with diabetes have MODY, you could look at the MODY probability calculator. So we hope that if you look at measures of autoimmunity and look at measures of insulin production, that's going to help you sort out type 1 diabetes from other types of diabetes. Thank you.
Thank you, Jay. So we're now going to move on to the next part of our webinar, our didactic. And I'm privileged to have my colleague, Dr. Dessi Zaharieva, here with us. And and Dessi completed her PhD at York University in Toronto, Canada, under the supervision of Dr. Mike Rodell in 2018. Her PhD research focused on strategies to reduce dysglycemia around exercise in adults with type 1 diabetes. Dessi is currently a postdoctoral scholar here at Stanford University, working under the supervision of Dr. David Maas. Her research focuses on exercise physiology and blood glucose management in type 1 diabetes, and we're fortunate to have Dessi part of our Echo Diabetes team in California. And I'm going to stop sharing my screen and pass it off to Dessi. Thanks again for joining us. And as a reminder, as we get the screen share set up, if you have questions during the presentation, please go ahead and type it into the Q&A box, and our faculty will answer your questions. If you have resources to share, please put it in the chat box. At the end of the presentation, we'll have five minutes for Q&A as well. Thanks again, Dessi.
Thank you very much. Thank you all for being here, and I am really excited to be sharing my insight on the topic of diabetes and exercise in the times of COVID. This is a very important topic, particularly with everything that's going on. We need to be extremely focused around physical activity and education. So I will just get started. I have no relevant financial relationships to disclose. Today's learning objectives, we will focus on utilizing exercise guidelines for type 1 and type 2 diabetes. We will describe glucose trends with various exercise modalities and also recommend diabetes management strategies during and after exercise, and also provide patients with exercise options during shelter in place. So we know that exercise recommendations based on the published literature for adults is 150 minutes of accumulated physical activity each week. So this works out to about 30 minutes of physical activity per day, with no more than 2 consecutive days off from physical activity. And in addition to the 150 minutes of accumulated activity, it is also recommended to be incorporating resistance exercise 2 to 3 times per week. For children and adolescents, these recommendations are slightly modified, a little bit different, leading to around 60 minutes of physical activity per day. It's important that in this population, for children and adolescents, the focus on top of moderate to vigorous physical activity incorporates activities that work on bone strengthening and muscle strengthening activities as well. So we have the recommendations. These have been published in numerous consensus guidelines and position statements. But what we see is issues around adherence for both type 1 and type 2 diabetes. In many studies, we've seen that less than 20% of patients with type 1 diabetes are actually exercising more than 2 times per week. And actually greater than 60% of patients with type 1 diabetes are entirely inactive. And overall, what we see is that the adherence to the recommendations tends to be lower with increasing age, and also lower in women. Now, there are studies that are kind of looking into why these occurrences are found. And generally with women, one thing that's been noticed is that an increased risk of hypoglycemia, which is sort of the next topic that I'll be looking at, discussing some of the barriers associated with physical activity. Other studies have looked at adults with type 2 diabetes, and it's been estimated that approximately 85% do not actually achieve the physical activity recommendations. So this all goes back to showing that we have recommendations that are not being met, and ultimately the biggest goal to increase adherence, in my opinion, comes around education. If we can increase education around safe exercise strategies, this will be the first step to helping with adherence. So here we're looking at some of the perceived barriers to physical activity. And these are just a few that have been published, and a number of these apply irrespective of, on the bar graph that we see on the right-hand side, both patients that are on insulin pumps or insulin injections. So things and factors like the weather, the work schedule, the fear of getting injured, but ultimately one of the most important factors or risks against a barrier to physical activity is actually the risk or fear of hypoglycemia. So other studies have actually looked at, with strategic modifications, to avoid hypoglycemia, so some examples being carbohydrate feeding or insulin dose adjustments, many individuals with type 1 diabetes are still reporting hypoglycemia or low glucose levels after exercise. So now we already know if we have this fear of hypoglycemia and worry about participating in physical activity, even when we try to do those modifications of adjusting insulin or carbohydrate needs, many of our patients are not successful, and we need to be finding better ways to educate on safe strategies. So this figure is looking at the differences in activities and the impact on blood glucose concentrations. So we know that there's a lot of glucose variability. There's also a lot of individual variability. And what we show here is in red in the top portion of that figure, more anaerobic based activity. So this is higher intensity or more intense exercise, but for shorter durations of time. So generally this could include something like sprinting or heavy weightlifting. These types of activities tend to cause glucose levels to rise. And this is kind of a factor, a multifaceted, but can be contributed to an increase in catecholamines, an increase in other metabolites like lactate that can also be causing glucose levels to rise. Now I'm going to skip over the purple section for just 1 minute and go down to the blue section of that figure where we see in the bottom portion the aerobic-based activities. So this is on the opposite end of the spectrum of more sustained activity, so lower intensity and longer duration activity. For this type of exercise, since the muscles are using up all of the glucose stores, and technically without replenishing those carbohydrate stores, oftentimes blood glucose trends tend to go down, and hypoglycemia is quite common in this type of activity. And this can be anything from biking to long distance running, but even just taking a walk to go to the grocery store can count towards aerobic based activity. Now, when we look at that middle section of the mixed aerobic and anaerobic activity, generally what we see is that in this type of exercise, it's a combination of anaerobic and aerobic activity. So some high sprint bursts interspersed with some lower intensity, longer duration bouts. And generally, this type of physical activity, something like soccer or basketball, these types of activities tend to keep our blood glucose levels a little bit more stable. So now we're going to look at, these are also published in the exercise guidelines, and keep in mind that these are suggested blood glucose starting points for exercise, and these also do vary depending on individuals. So just use this as kind of a basis of a starting point, and it may need to be tailored and modified and individualized for each person with diabetes. So when we look at the middle portion of this table, we can look at aerobic or low intensity exercise, as we just mentioned previously, the type of activity that generally causes blood glucose levels to fall. And on the right-hand side of the table, we look at more anaerobic or high intensity activities. So generally something that's going to cause glucose levels to rise. When we start at the bottom part of the table, looking at glucose levels less than 90 milligrams per deciliter, oftentimes, irrespective of the type of exercise being done, this is an increased risk of hypoglycemia. Especially if you're doing more low intensity and longer duration activity, carbohydrates are definitely recommended and rechecking blood glucose before starting exercise. Considering insulin adjustments, but oftentimes these are done well in advance of exercise. We've published that for type 1 diabetes on insulin pump therapy, generally adjusting for a 60-minute bout of exercise, reducing insulin levels by 50 to 80% on the insulin pump. Basal insulin levels by that much can actually help reduce the likelihood of hypoglycemia. But again, this is often done well in advance of exercise. Whereas with anaerobic activity with glucose levels below 90, this may be okay to begin if a predictable rise is seen. So meaning if carbohydrates have been consumed or using continuous glucose monitoring, if you see trend arrows up, it may be okay to start exercise in this range. And when glucose levels are between 90 and 124 milligrams per deciliter, generally both aerobic and anaerobic types of activity are okay to start. And moving to a higher glucose range of 126 to 180, also generally okay to start both aerobic or anaerobic types of physical activity. But remembering that if you are going to be doing more anaerobic or high intensity exercise, the higher your glucose levels are, you have an increased risk of elevations in glucose levels as well. So once we get to up to 270 milligrams per deciliter, it still may be okay to do both types of activity, but just be aware that studies have shown performance impairments once you are at the higher threshold. So people often will say that they don't feel as well and don't feel like they're performing at their best with glucose levels in the 270 range. And once we get above 270 milligrams per deciliter, this is really important to discuss because oftentimes we will say, do not exercise. You know, we want to make sure that our patients are safe, but it's very important that participants are checking ketones if they're going to be exercising with glucose levels above 270 milligrams per deciliter. If ketone levels are small to moderate, then generally it's okay to start aerobic-based activity, so something that's going to be low intensity and for longer duration. And even considering a 50% correction bolus to help bring glucose levels down. But just being aware that any kind of correction bolus that's going to be taken, in addition to an exercise bout, just increases the risk of hypoglycemia in recovery. And with anaerobic activity, altogether, it should be avoided in the glucose range of 270 milligrams per deciliter or higher, just for that increased risk of higher glucose levels and glucose concentrations. Here we are looking at a study. It was a review paper that was published by Dr. Chetty and colleagues in Australia, looking at a structured approach to exercise consultation. I found that this was a very important review paper that I wanted to share with everyone as what should be the ultimate goal when we focus on increasing minutes of physical activity, trying to get individuals closer to their goals. The ultimate focus should be based on the center of that circle, and it should be the patient goal. We need to find out what the goal is of the patient to find out if they are looking to lose weight, if they are looking to exercise for performance reasons, for increased metabolic fitness, or just for competition purposes. All of those purposes are going to be quite different in how we do our exercise consultation. So then we move our way to the outward parts of the circle, trying to understand the next steps of what intensity, type, and duration of physical activity our patients are going to be doing. And then eventually understanding what types of bolus and basal conditions we can adjust. So for example, if we are over 60 to 90 minutes pre-exercise and on insulin pump therapy, adjusting basal insulin levels is an option for aerobic-based activity. However, if an individual is on multiple daily injections, that basal adjustment cannot be made 90 minutes before exercise. Oftentimes it would have to be made the day prior or in the morning when long-acting insulin is being taken. And then we also look at planned versus unplanned activity. This one's also very important because planned activity gives us more opportunities to make changes to our insulin and carbohydrates. But oftentimes, especially in the pediatric population, unplanned activity is something that just happens spontaneously. You didn't realize you were going to exercise or something came up and you don't have the time to adjust your insulin or carbohydrate needs. In this situation with unplanned activity, generally carbohydrate feeding is the only option. You've sort of eliminated the chance to be doing any sort of insulin dose adjustments at the time of exercise. And then the last part of that circle is looking at previous days hypoglycemia. So important to ask your patient whether they have experienced hypoglycemia the day prior to exercise, because this will also increase the risk of hypoglycemia for the time of exercise and in recovery. So now we get into what has been happening during this entire pandemic, and many people are now saying that it's been very difficult to be as physically active, particularly for those individuals that are high levels of fitness and very elite level athletes. They may not have the resources. And so a lot of the times what we hear for our patients is that they say, we don't have any equipment at home. But what we tend to say is that's generally not a problem. Of course, it's going to change how some of the activities look and what types of activities you may be doing. But many activities require no or very little equipment. So these are just some examples of activities that can be done with very little to no equipment, things like yoga, walking. There's actually YouTube videos and quite a few available that we'll discuss in the next section that are available off of an internet or a smartphone device, as well as something like running and biking, generally with little to no equipment. Some people will say that they prefer resistance type exercise. So now they want to be doing things involving weights, but maybe they don't have something like a squat rack available or dumbbells available at home. I know during the pandemic, it's been very difficult to be finding, just even the cost of dumbbells has gone up significantly, and it's very difficult to be finding these things online because a lot of them have been on back order. So what we've seen is that people are now modifying their activities and using things like furniture, their backpacks, soup cans, and water bottles as kind of modified weights. Now, we're not telling your participants or the patients to go in and start lifting furniture and making it very difficult. You know, you're not going to be lifting a couch or anything, but there are many things like baskets around the house or putting water bottles that are filled inside your backpack as a weighted vest. So here are some examples of free YouTube exercise channels that we wanted to provide resources for all of your patients. And importantly, here we've added all of the links to at least a couple of the yoga channels that are available on YouTube. These are by no means the only available channels. There are many others that you can find on YouTube, but importantly, these were ones that cover kind of a wide range, anywhere from beginner level of yoga to advanced level of yoga. For example, Core Power Yoga is one that does pre-recorded classes that range from 30 to 75 minutes and offers things like guided breathing and meditation. I think we really need to focus on our mental health right now, especially during this pandemic. It's been very hard being inside and, you know, in limited space. It's very difficult to be doing certain types of physical activity. Tara Stiles and Yoga with Adrienne both offer modifications to small space workouts for yoga, and also things like weight loss and self-love and meditation. And then Yoga with Cassandra is another option. This one is actually really great for individuals that are finding that they don't have the time in their day to do physical activity. So this one can offer videos that are as short as 10 minutes and from beginner to advanced level of yoga. Now, some people might say yoga is not what they prefer as their choice of physical activity, and that's okay. We wanted to cover a wide range of physical activities and different types of things that can be done in the home. So these are other free YouTube channels that are available. Fitness Blender, for example, offers over 500 at-home workouts. The HIIT is referring to high intensity interval training, things like just sprint anaerobic-based activities, but also things that may involve some weight. And other activities such as strength, Pilates, and stretching. There is always the option for these Fitness Blender activities to be body weight with no equipment. And the body project activities are great because they're for everybody. They do high intensity cardio, resistance training, as well as yoga. You can also create an account on YouTube, and then you can access videos that aren't available to everybody. And the Body Coach TV is another option for weekly workout videos from beginner to advanced, and also senior specific workouts. And Pop Sugar Fitness is one that's really nice because it's a little bit different than the others. There's hundreds of different free workout videos, but also a lot of dancing-based videos for people that really enjoy dance, and often with no equipment necessary. So these are a little bit different. Rather than going on YouTube to find your activities that you can do, these are free exercise apps. So generally for these ones, you don't need to create an account. For some of them you will, but no credit card information is required. So for example, during this pandemic, Nike has offered up their Nike Training Center and Nike Run Club app for free. And so importantly, oftentimes that they would have very advanced type activities or premium type classes that would be led by a Nike fitness trainer. These ones are actually available for free during the pandemic. Tone It Up and Fit On and 7-Minute Workout are all very similar. They offer a wide variety of activities that range from high intensity to yoga to stretching. And actually, some of them also offer Tone It Up and Fit On activities that are specific for working out with children as well. So activities that you can do with your kids. Fit On specifically has options for that as well. Tone It Up also offers one little interesting quirk that some people like to do activities with celebrities, and they've got pre-recorded videos that are free to do with certain celebrities if you'd like to follow along with those. Glucose Zone, I won't touch on in too much detail right now because I will focus on this a little bit later in a different slide, but Glucose Zone is also available for free during the pandemic, and it is an app that is actually specific for type 1 and type 2 diabetes. Whereas none of these other apps or websites actually tailor anything to diabetes specific, adjustments or modifications that may need to be made for living with type 1 or type 2 diabetes. But Glucose Zone does offer this. So this is another example of free exercise apps, but with the parentheses, free, it says that generally there's a trial period, but oftentimes you do need to put in credit card information to sign up. And you need to make sure that if your patients are going to be using these apps, that they are making sure to cancel before the trial ends. So oftentimes you need to create this account. So things like Les Mills offers free 14 days at the moment with a variety of activities, even for kids. Strava is a little bit different. It's more for cycling, cyclists and runners, and this one's free at the moment for 30 days. This one's fun because you can share your activities with friends and followers, so they can sort of keep you accountable and help you stay motivated. This one is actually designed by athletes for athletes, so oftentimes people prefer to do this, especially if they're very competitive. Peloton has also offered now a free 30 days, and this one also offers a variety of activities such as yoga, meditation, and strength. Peloton used to be specific to basically bike-based exercise, but now they have opened it up to addressing many different types of exercise. And just looking at some additional patient resources, these are excellent resources for kids. So as some of the earlier ones that I talked about, like Fit On, where you can do activities with your kids, this one is specifically for kids. So it ranges from very young ages, Cosmic Kids Yoga, Pancake Manor, and Go Noodle. All of those resources are available, and you can press the link to access those. And there's also activities for limited mobility or exercise for beginners. So not everybody needs to be an elite athlete to be trying to increase their minutes of physical activity. C25K is actually couched to 5K, and this is an app that is more focused on especially type 2 diabetes or people that are just simply looking to increase their minutes of physical activity, get closer to that goal of 150 minutes per week. And Body Project also offers beginner videos for people that aren't as comfortable or familiar doing physical activity and specific exercises. And Kaiser Permanente offers some limited mobility YouTube videos as well, looking at something like a seated upper body exercise video. So just to wrap up, we wanted to focus on a couple of areas of digital health technology and diabetes management. I think what we need to focus on during this pandemic is understanding that self-love and taking care of our bodies is very important, because we are, a lot of people are stuck indoors and not able to do the activities that maybe they would have preferred to do. Going outside for a run, maybe they don't feel comfortable doing this. So we need to find, different apps or technologies or other resources that may help people be more physically active. So not all of these are available because they're still being processed or kind of in the works. For example, the T1 exercise is one example of an early release app for management of type 1 diabetes. This one focuses on multiple daily injections and also insulin pump therapy. It offers personalized feedback and reminders. This was actually developed from an exercise physiology center in Dublin, Ireland, and uses decision trees for basically exercise management strategies. Diabits, on the other hand, it is still focused on type 1 diabetes, and this one is a glucose prediction app that is still being tested, but it's been tested in a pilot study in British Columbia, Canada, to look at integrating continuous glucose monitoring and pump therapy. And you can also integrate that with heart rate technology, so something from a wearable device such as an Apple Watch, to help try and understand our physical activity and blood glucose tracings. And Glucose Buddy, on the other hand, offers basically a platform to be able to log physical activity in a variety of different ways. Our exercises, our medications. This one is for type 1 and type 2 diabetes, and also provides reminders for checking our blood sugars. And the interesting thing about Glucose Buddy is you can actually export a file of up to 1 month and send it directly to your healthcare practitioner. So this would be very good if you would like to get access to the types of physical activity and maybe try and understand the patterns of blood glucose around exercise for your patients. OneDrop is another one that is for type 1 and type 2 diabetes, but type 2 specifically insulin dependent. It doesn't offer any active coaching, but it does offer personalized feedback. And this one also has a built-in food library and allows integration of continuous glucose monitoring and also different glucose monitoring devices. The BANT app is for type 1 diabetes, and this app is an iPhone-based app at the moment, and it was developed in Toronto, Canada. The name BANT actually came from Dr. Frederick Banting, and the idea of this app is to be able to track your meals, your blood glucose concentrations. No active coaching at the moment, but a lot of personalized feedback and reminders are available. And then going to My Sugar, this was an app that was originated in Austria, but is now owned by Roche. And so now it focuses on type 1 and type 2 diabetes, and doesn't offer any coaching, but more personalized feedback as well. And then just to finish off with Glucose Zone, this is the one I wanted to touch on again, because this is a really important app, in my opinion, that addresses both type 1 and type 2 diabetes for a variety of fitness levels, from beginner to advanced. This one does provide active coaching. And the most important thing, for example, in Glucose Zone, if you enter your blood glucose concentration, whether it be through finger stick or through your continuous glucose monitoring, based on that glucose value, you will already have some kind of coaching on what type of activity to perform. For example, if glucose levels are elevated above 200 milligrams per deciliter, as we said, typically aerobic-based exercise will be safer to do if blood glucose levels are elevated. Whereas if glucose levels are a lot lower, Glucose Zone will take that into consideration and offer doing more of an anaerobic bout of activity. So these are just some of the digital health platforms that are available. Again, these are by no means all of the ones that are available. This one was published in a paper last year by Dr. Riddell and colleagues, and it's available that you can find all of these links to those websites to access the platforms as well. And at this point, I would like to say thank you for your time, and I hope that everyone is focused on increasing levels of physical activity, even if that means just a little bit of guidance and support to get us closer to our 150 minutes of physical activity per week. Thank you, everyone.
Thank you, Dessi. Thanks so much also for sharing those excellent resources. And I also put those in the chat box for those of you who want to take a look at that. Once again, this presentation will be available on demand, and you also have access to the slide deck. I'm going to open up now to Q&A. If you all have questions, there's been great questions coming in. If any faculty want to bring up any questions that came up and that you responded to, and in the meantime, if anyone has some additional questions, please go ahead and type them in, and we will respond to them.
This is Leslie in Nebraska. I think there was one really good question about the importance of exercising in the fasted state versus with insulin on board. Any thoughts on that?
Absolutely, that's a fantastic question. So this is something that's very near and dear to my heart because I actually live with type 1 diabetes myself, and I think anyone that lives with type 1 diabetes can definitely speak on this of a personal kind of story. When you exercise with insulin on board, it's always going to be an added challenge. For me, I actually consider this one of the greatest challenges to exercise because if we have active insulin in our body, as soon as we start to exercise, one thing that's generally been seen is that insulin absorption increases at the start of exercise. So that, for example, subcutaneous depot of insulin under the skin gets absorbed with that increased blood flow and increased circulation. That can cause our blood glucose levels to drop even more drastically. So if we eliminate one of those factors and try to consider exercising in the fasted state, we're often going to have more success in stabilizing our glucose levels because we have one less variable or factor to have to take into consideration. The more insulin that we have in our body also means that oftentimes carbohydrate feeding will be necessary prior to exercise onset. So that's also one thing to consider because sometimes, even though we want to exercise, we can't change the fact that we already have circulating insulin in our bodies. So just know that if that is the situation and the case, that carbohydrate feeding will likely be the optimal way to go. Otherwise, delaying exercise till a little bit later when circulating insulin levels go down a little bit. And one last thing about fasted exercise as well, there's a lot of research that looks at fasted exercise in the morning, for example, with increased kind of cortisol and other hormones taking into effect in the morning, we oftentimes see that blood glucose levels are more stable in the morning in comparison to an afternoon bout of exercise. So morning activity can also be a little bit safer for people that are at risk or worried about hypoglycemia during activity.
Dessi, sorry, there was a good question. If you can suggest any exercise for someone who is wheelchair bound.
Yes, great question. So about wheelchair bound, unfortunately, none of these apps that you can download pretty much will focus specifically on limited mobility or wheelchair bound, but I was very careful in trying to find something for absolutely everyone. Some of those additional resources do provide links, and they do have a couple of resources there for doing limited mobility or wheelchair bound exercises, something that may be more focused on upper body, whether it be with any type of weight or with just body weight as well. And so there are some resources available there.
This is Leslie again.
Any other questions?
Yeah, just thoughts about microdosing with glucagon. You know, now Gvoke makes that shelf-stable little syringe where you don't have to give an all-in-one dose. And I've had some patients asking about, well, can I take, you know, a little squirt of this before exercise? And obviously no guidelines, but wanted to get your thoughts on that.
That's also a great question. So the mini dose glucagon, as we're getting into newer technologies and newer devices and newer things that are available, mini dose glucagon is also something I've been very interested in and have kind of focused on during my PhD, because that was another thing for my focus. I actually do mixed martial arts. And so for me as a fighter, I can't be always consuming carbohydrates. So some people just do not prefer to be eating carbohydrates all the time to be treating lows. And we don't want that to eliminate kind of the option to be doing physical activity safely. So there actually is a publication by Dr. Riddell, and I'll be able to share this publication on mini dose glucagon that's been kind of getting closer into the, you know, the world of us using mini dose glucagon in the real world. Unfortunately, there's no specific guidelines on how to dose on doing this, but it is something that's definitely being studied further. There are publications that do focus on this as an alternate option for, you know, people that are trying to avoid carbohydrate feeding for avoiding hypoglycemia. So that is always an option, particularly for longer duration activities or anything that's going to be over 60 minutes in duration, and aerobic based in nature. So that's going to be more of an increased risk of hypoglycemia as well.
And this is Nick. Thanks again. And you know, in your presentation, you mentioned kind of some dose decreases, maybe like percentage for exercise. And some people, you know, many of our patients, they have carb ratios, but they just kind of give the same dose every meal. Any kind of general like guidance, like simplicity in terms of, okay, if you're going to do exercise, what should you do with your dose with your meal if you're going to go do exercise after it, if you can't do it in the fasting state?
Definitely. So that's also a great question. And I'm happy to share other resources specifically for healthcare providers to be able to look into more details themselves, because the exercise consensus guidelines provide very nice tables on the percentages of how much bolus or basal insulin should be reduced and when those should be done. So one example I did mention, if exercise is going to be, for example, 60 to 90 minutes after, you can make those insulin dose adjustments. So if I'm going to exercise in 90 minutes, the idea would be to be able to reduce basal insulin by 50 to 80%. And so that was published in Diabetes Care, and we can share those resources as well. That's for basal specifically, but for bolus adjustments, and this would be specific for maybe patients on multiple daily injections, or for individuals that just feel like they are at increased risk of hypoglycemia, you can reduce bolus doses for the meal prior to exercise. And these can vary from 25 to 75% reduction in the bolus in the basically meal prior to exercise. And there's also reductions that are recommended in recovery as well. So not taking kind of your full dose because you have increased insulin sensitivity post-exercise as well. So I know it can seem quite complicated, but always understanding that if you don't have much time to pre-plan, the meal prior to exercise would be a good opportunity to start with a small bolus reduction if you wanted to start with something as little as 25% and see how it works. Unfortunately, at this time, it's still a lot of trial and error, and there's still a lot of individual variability. So what we recommend for one person may not apply for the next person. So it takes a little bit of trial and error, and I think we all know that. That's one of the biggest challenges of diabetes.
Thanks again, Desi. On what strategies can be used to minimize anxiety during COVID. Obviously, this case presentation also hits home to that in terms of just anxiety in terms of receiving care at the local hospital. Jesse, you want to go ahead and comment on this question?
Sure. Just as a little intro, I wanted to show this Yerkes-Dodson law, which is arousal in the sympathetic nervous system can be a positive thing when you're at relatively low levels, but once you hit that hump at the top, once you've hit optimal arousal and optimal performance, everything to the right of that curve is anxiety. So while, you know, it's just one end of a spectrum that we're pretty much on all the time when we think about anxiety. Next slide. So there is a lot of anxiety. It's increased across a lot of people right now due to the pandemic. And the first step is to really be aware of your own stress levels. What are the signs for you that you're beginning to be anxious, and what are the signs that you are overly anxious? It's also important for people to temper expectations of themselves and those around them, which might include cutting down on daily objectives at work and home and reevaluating priorities on a regular basis. You know, like a life-threatening priorities versus it would be nice if I repainted my house kind of priorities. Also taking care of your body. Dessi had a wonderful presentation today on the importance of exercise and how to maintain that. Exercise is an incredible strategy to manage anxiety, but also making sure that sleeping and eating habits are on track as well. Making sure that you take care of your mind, so scheduling time to unwind and take breaks during the day, and then also making sure that you're devoting time to connect with others to actually discuss some of the stressors in your life or totally unplug from them completely with focusing on those types of interactions with people you care about. And lastly, to make sure that you connect with mental health services if you become functionally impaired by your anxiety symptoms and or they do not improve over time. And then the last slide I wanted to share was some great resources that have been provided online with, these are really nice like short articles as well as handouts that to use as well as share with patients regarding, you know, staying emotionally well and managing anxiety during a pandemic and how to navigate that despite the barriers of social distancing, quarantine, and isolation. Thank you.